Hello, I'm Jan Leifman.
I'm Gayatri Pramal Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Paul Feuerstadt. Dr. Feuerstadt is a gastroenterologist at the PACT Gastroenterology Center, an assistant clinical professor of medicine in the Division of Digestive Diseases at Yale New Haven Hospital.
In today's presentation, Dr. Feuerstadt discusses the epidemiology, pathophysiology, diagnosis, and management of Clostridium difficile.
Did you know that Dr. Feuerstadt is a globally renowned clinical trialist who has directed over 100 clinical trials? He's been recognized amongst Connecticut Magazine's best doctors and a recipient of the 2020 American College of Gastroenterology Section Award. He has also co-chaired multiple international conferences, including the annual C. diff Foundation International Conference and Patient and Family C. diff Symposium.
He's truly a great visionary in the field of medicine.
So let's tune in. Let's tune in and learn from this global leader.
So it shouldn't be any surprise to anybody who's participating in this discussion tonight that C. difficile is a major problem in the United States. In fact, the Centers for Disease Control and Prevention issued a threat level of urgent for C. difficile in 2013 and then again in 2019. And that was based on studies like the study I'm showing you here that was published in the New England Journal of Medicine in 2020. Within this study, the study organizers looked at something called the Emerging Infection Program. The Emerging Infection Program looks at 10 counties throughout the United States that are thought to be representative of the broader population, projects the data across those 10 counties on a national scale. In 2011, it was estimated that 476,400 individuals were diagnosed with C. difficile in the United States. In 2017, a similar number of positive tests were identified, but the estimated incidence of C. difficile was 365,200. So what explains the difference in the number of positive tests from the estimated incidence? It turns out that in 2011, the bulk of the diagnoses of C. difficile were with the EIA, or enzyme-linked immunoassay, whereas in 2017, the bulk of the diagnoses were with the polymerase chain reaction. The PCR assay has a tendency to overdiagnose C. difficile, which is why, in order to compare apples to apples, there was a normalization effect. And we'll get more into diagnostics later on in the presentation. Importantly also, though, there was a shift from healthcare-associated infections in 2011, accounting for about 2/3 of all infections, to 2017, where they accounted for about 50%. So what accounted for that change? Well, all of us know this who work in the hospital: better infection control, antimicrobial stewardship, more aggressive treatments of C. difficile. The overall incidence of community-associated infections remained about the same in terms of absolute numbers, but the percentage accounted for increased because the overall numbers decreased. So what is a healthcare-associated infection? A healthcare-associated infection is any infection that has an onset of symptoms greater than 72 hours after admission to the hospital or within 90 days of discharge from the hospital. Why is this important? Healthcare-associated infections are associated with higher rates of recurrence and higher mortality. Now let's dig a little bit deeper on these healthcare-associated infections. And this is some epidemiologic data that was presented also in the New England Journal of Medicine in 2018. It looked at the incidence of healthcare-associated infections in 2011 and compared them with 2015. And overall, we should give ourselves a pat on the back. We are doing better because in 2011, between May and October, the incidence of healthcare-associated infections was about 4.0%. In 2015, that actually decreased to 3.2%. What accounted for that decrease? Healthcare systems being focused on these problematic infections. The classifications remain the same: surgical site infections, pneumonias, gastrointestinal infections, urinary tract infections, as well as primary bloodstream infections. But what you'll notice from this slide is that between 2011 and 2015, there was a statistically significant decrease in the proportion of infections accounted for by surgical site infections, as well as urinary tract infections. In fact, the proportion of infections accounted for by GI infections increased from 17.1 to 21.3%. And of that 21.3%, 72.5% was C. difficile in 2015. C. difficile is the most common healthcare-associated infection, accounting for 15.5% of all healthcare-associated infections, more than VRE, more than MRSA. This infection requires respect. Let's now shift gears and talk about the pathophysiology. And I'm going to take us back to our textbook years and remind us what the microbiota is. The microbiota is a group of microorganisms, 100 trillion within the human digestive tract, 500 to 1,000 different species within the human digestive tract. Now, we know the most about the bacteria, but the microorganisms that we see include bacteria, archaea, fungi, protozoa, and yeast. The most common bacterial phyla that we see are the Bacteroidetes, Firmicutes, Actinobacteria, Proteobacteria, Verrucomicrobia, as well as Fusobacteria. When we talk about the microbiota, there are certain terms that we use, and giving it a 40,000-foot view, what is the microbiota? The microbiota is a group of microorganisms living in a confined and defined space. Now, we frequently use the term microbiome and microbiota interchangeably, but they're actually very different things. The microbiome is the genetic complement of all of the microorganisms when they're broken down. Dysbiosis is any differentiation of the microbiota from normal. And probably the most important concept, but the concept that we understand the least, is the metabolome. We don't necessarily care which microorganisms live in our gut. What we do care about is how they metabolically interact with our body, either protecting against disease or promoting disease. So now, putting all this together, we'll go back to our textbook years again. And I'll remind you that C. difficile is a gram-positive, spore-forming, anaerobic rod. And there are two main phases of C. difficile infection: the spore phase and the vegetative phase. As a clinician, the phase that I most frequently think about is the vegetative phase, because this is the phase that releases two main toxins, toxin A and toxin B, most commonly associated with the diarrheal syndrome of C. difficile. The vegetative phase is susceptible to gastric acid and susceptible to alcohol-based hand sanitizers. Plainly stated, when it comes in contact with these things, it gets wiped out. Very importantly, the vegetative phase is the phase that antimicrobials largely treat and control, which is why when patients are on antimicrobials, their symptoms usually get better if the patient has active C. difficile infection. Alternatively, the spore phase is a much more resistant phase. The spore phase is resistant to gastric acid and resistant to alcohol-based hand sanitizers. In fact, the spore phase can last on dry surfaces on the order of 6 months and remain viable. Importantly, it's the microbiota that helps eradicate the spore phase, because the microbiota is what gives it that knockout punch after the antimicrobials have come off. So what do we need to have happen for somebody to get C. difficile? Classically, two things have to happen. One, you have to have an exposure to the bacteria. And two, you have to have dysbiosis. So what actually happens is we swallow the spore phase. The spore phase is resistant to our gastric acid, gets through our gastric acid into our small bowel, where there's a conversion to the vegetative phase called germination. The vegetative phase multiplies, divides, and multiplies some more as it builds an army of sorts heading towards the colon. But you heard from the introduction that I'm a gastroenterologist, and I think the colon is a brilliant organ, because the colon has its own defense system, independent of the blood-borne defense system that protects it. What is that defense system? The microbiota, or colonization resistance. What classically weakens the microbiota or colonization resistance? Amoxicillin, ampicillin, clarithromycin, fluoroquinolones, and cephalosporins. We weaken colonization resistance, creating an environment that's more welcoming for the C. difficile to proliferate, and it proliferates, releasing those toxins and causing the symptoms that I've already outlined. So what are some risk factors for C. difficile? And I like to group these into 3 different categories: demographics, medication exposure, and environment. From a demographic standpoint, age over 65, female gender, any form of immune compromise, chronic kidney disease, HIV, inflammatory bowel disease, diabetes is an important one, any distant history of C. difficile, Medication exposures, we spoke about the antimicrobials already. As a gastroenterologist, though, tons of patients in my practice and walking through my office are on proton pump inhibitors and histamine blockers. And there is a direct correlation between initial C. difficile infection in PPIs and histamine blockers and recurrent. So what is the connection there? Why is there a connection there? Well, the astute person listening will remember just a couple minutes ago, I explained that the vegetative phase is susceptible to gastric acid. So theoretically, if you reduce that gastric acid, more vegetative phase will get through, and therefore you're more likely to get the infection and more likely to get a recurrence. That's the theory that we had up until about 2015, when a very simple study was conducted at Columbia University, but a very impactful one. Within that study, they looked at 12 20-year-olds who were otherwise healthy on no other medications, characterized their microbiota before intervention, and then gave them omeprazole 40 milligrams twice daily for 3 months. What did they find? When they compared the microbiota at the end of the treatment with the microbiota before the treatment, there were increases in Enterococci and Streptococci and decreases in Clostridioides. Plainly stated, the microbiota was altered in a way that favored proliferation of C. difficile or a weakening of the so-called colonization resistance. Now, the environment can also play a key role in patients getting C. difficile. People who spend significant amounts of time in the hospital or in skilled nursing facilities are at increased risk. Why? Well, it's logical. People who are in skilled nursing facilities and hospitals have all the other risk factors. They're also much more likely to get C. difficile, and they're usually debilitated and at risk for C. difficile. And there's a number of different epidemiologic elements to be considered. What about the toilets? Let's think about the toilets. Mark Wilcox, probably one of the world's foremost thought leaders on infection control and C. difficile infection, did a very simple study about a decade ago. He had a bunch of individuals with C. difficile move their bowels in the toilet. He flushed the toilet and measured the air quality over the toilet at fixed time points. Whatever you're thinking is exactly correct. The yuck factor is through the roof. However, within 60 minutes, the volume of the spore in the vegetative phase over the toilet decreases 8-fold, and within 90 minutes, it decreases 11-fold. And there was one intervention that they did that completely shut down the aerosolization of the spore in the vegetative phase. What was that? They put the toilet lid down before they flushed. A very logical thing to do in a private home or apartment environment. But what's the problem with that in hospitals? There are no toilet lids and there are no toilet seat covers because their nidus is to spread infection. So we see that even something simple like this can have a profound impact on the spread of C. difficile. Let's now shift gears and talk about recurrence. And it's estimated that 25 up to 35% of all people treated with metronidazole and vancomycin initially will recur. And of those that recur, 40 to 50% will go on to recur after that, and 50 to 60% will get caught in the cycle of recurrence after recurrence after recurrence. A true challenge for us as clinicians to take care of these patients. What are the risk factors for recurrence? They mimic the risk factors for initial infection: demographics, medication exposures, environment, with the added addition of bacterial factors, including hypervirulent strains and severe infections. Now, as I alluded to before, when we spoke about the vegetative phase and the spore phase, I said that the vegetative phase releases toxins and stimulates symptoms. What I mentioned also was that the spore phase was a hardier phase, and the spore phase explains the spread of C. difficile, but also the spore phase hangs out in our systems after completion of antimicrobial therapy, and it's up to the microbiota to give that spore phase the knockout punch. And this study, a simple study, but a very impactful study, shows what can happen without intervention on the microbiota during a time called the window of vulnerability, the 3 months following completion of antimicrobial therapy, when the microbiota is giving that spore phase the knockout punch. The Dracanja study group looked retrospectively back at 246 individuals. 25% of them were receiving antimicrobials for indications other than C. difficile at the same time as their treatment of C. difficile, and 33% received antimicrobials after treatment of C. difficile within this window of vulnerability. And then they looked at rates of recurrence. Recurrence rates in the group that received no concomitant antimicrobials, where the microbiota is able to self-heal without intervention, 16%. Recurrence rates in the group that received concomitant antimicrobials at the same time as our treatment of C. difficile shot up to 31%. However, recurrence rates in the group that received antimicrobials in the 3 months subsequent to the treatment of C. difficile, that shot up to 48%, or a mere coin flip of whether or not the patient was going to recur. So this again speaks to the impact and the importance of the microbiota self-healing after treatment of C. difficile, but if it takes a hit, much more likely to recur. And these cycles of recurrence have a massive impact on patients, both in terms of abdominal pain and diarrhea, but other complications. This is data that our study group presented last year. We looked at the number of episodes of C. difficile that commercially insured patients had, and then looked at rates of sepsis and colectomy within the subsequent 12 months. With one episode of C. difficile, 16.5% of individuals within a year had a diagnosis of sepsis, and 4.6% had a colectomy. With 3 or more episodes of C. difficile, 43.3% ended up septic within a year, and 10.5% had their colon removed. So this doesn't just affect the abdominal pain and diarrhea in patients. There are other elements to this. And another essential element to consider is that we treat individuals. We don't just treat the specific disease. There is a psychological element that is associated with C. difficile infection. And this is data from a study, a survey that we had patients complete. About 1/3 of them had active C. difficile. 2/3 of them had a distant history of C. difficile, meaning more than 3 months in the past. 350 total patients filled out the survey, and the survey had 5 different categories that it asked patients about. 1, the physical implications, abdominal pain, diarrhea, fevers, sweats, the psychological effects, post-traumatic stress disorder, anxiety, depression. Asked about adaptational behaviors as a result of the recurrent C. difficile, including do they change what they eat, when they eat, how they interact with other people, the time of day that they leave their house, the relational impact. Are they comfortable going out socially without figuring out where the bathroom is? And finally, productivity. Are they able to go to work and be productive at work? And across the board for physical, psychological, adaptational, and relational, both the patients with active C. difficile and a distant history of C. difficile, more than 50% of them were impacted. In terms of productivity and their ability to earn a paycheck, 51% with active C. difficile were unable to, 34% with a history. So we need to appreciate the impact on the entire individual. And let's now shift gears and talk about diagnosis, because if we're not properly diagnosing this, then we're not properly treating the infection. And it's completely embarrassing that in 2022, I have to show you a slide like this to diagnose C. difficile, where we normally use our cell phones to control the world, but we don't have a simple test to diagnose an infection that's the most common healthcare associated infection. Unfortunately, we don't. There are 5 tests that you see on this slide, but immediately we should remove 2 of them: the cell culture cytotoxin neutralization, as well as toxigenic culture, because they're not widely commercially available. So what we're left with are 3 tests: the enzyme-linked immunoassay, or EIA, the GDH assay, or glutamate dehydrogenase assay, and then the polymerase chain reaction, or PCR assay. The enzyme-linked immunoassay is the only of those 3 tests that detects active toxigenic C. difficile, or the active infection, because the EIA detects the toxin. Well, now you're saying, great, we have a test that detects the toxin that's widely available. Why don't we just use it as a solitary test? Not so fast. The sensitivity of this assay is not good enough to have it as a solitary test. So plainly stated, if you're positive, yeah, you most likely have the infection. If you're negative, we can't say that you don't have the infection. So what we've done is we've coupled it to another test, the GDH assay, or glutamate dehydrogenase assay. Glutamate dehydrogenase is an enzyme that's released broadly by Clostridioides species, but not specifically by toxigenic Clostridioides species. So in effect, this is a test that has a high negative predictive value. So if you're negative for this, it's unlikely that you have toxigenic C. difficile, but if you're positive, you might have it. Well, when you combine these 2 tests, you get a much more powerful assay. If they're both negative, the patient's negative. If they're both positive, the patient's positive. But if they're discordant, that's a situation where we need another test to adjudicate. And that takes the form of the PCR assay, or polymerase chain reaction. The PCR assay is an assay that detects the genes that code for the toxin for C. difficile. By doing that, it tests for the bacteria, but not whether the bacteria is producing toxin. To adjudicate the other test, if it's positive, the patient's positive. If it's negative, the patient's negative. However, used as its own assay, it will detect what we call colonizers. People who have C. difficile in their system, but aren't producing the toxins. Therefore, it's not explaining the symptoms. Therefore, when we use the PCR assay, patients should have at least 3 liquid bowel movements in a 24-hour period. The stool should take the shape of the specimen container that it is collected in. And importantly, patients should not be on laxatives. If all 3 of those criteria are met, then yes, this can give you a true positive. But if you remember back to the epidemiology section, I mentioned that there's been a shift in the tools that we use to diagnose C. difficile. In 2011, it was largely EIA, which we believe to be more true positive. In 2017, it was more PCR. And because PCR is associated with these colonizers, there was that adjustment that we saw. So remember the strengths and limitations of the assays that we have to detect C. difficile, and the clinical context and the history is essential to be coupled with these assays, not to just simply blindly send the test. So with all this foundational knowledge in mind, let's get to the bottom line, treating these patients. It's essential to understand that antimicrobials treat that vegetative phase, the phase that releases toxins. Alternatively, the spore phase is eradicated by the microbiota. And the best place to start when we talk about treatment is the updated 2021 IDSA, Infectious Disease Society of America, and Society of Healthcare Epidemiologists of America guidelines. And this was lead authored by Stu Johnson. And there has been a significant change in the recommended antimicrobials through the PICO analysis that they presented. For initial infection of C. difficile, it is now preferred that patients receive fidaxomicin 200 milligrams twice daily for 10 days. An acceptable alternative is vancomycin 125 milligrams 4 times daily for 10 days. And finally, if neither of those are available, the white cell count's less than 15,000 and the creatinine is less than 1.5 milligrams per deciliter, then metronidazole 500 milligrams PO TID might be considered. So how did we get here? Metronidazole has largely been removed from the treatment algorithm. Why? It actually came from this study, which was a study that looked at a product called Telavimer. So now you're saying, okay, wait a second. He mentioned metronidazole being removed from the treatment recommendations, and then he's talking about a product called Telavimer. The point here is a study was conducted between 2005 and 2007 looking at Telavimer, an ion binder that theoretically would bind toxin A and toxin B and treat C. difficile as a solitary treatment. The bottom line is it was completely ineffective, but we had 2 large-scale trials looking at Telavimer with 2 control groups, metronidazole and vancomycin. So we had head-to-head data from 2005 to 2007, but if you look at the bottom right of this slide, this study wasn't published until 2014 because they didn't realize what they were sitting on, which was head-to-head data from metronidazole and vancomycin. And I'll point your attention to the right-hand bar graph combining the 2 parallel studies. Overall efficacy of vancomycin, 81.1% versus 72.7% for the metronidazole. So as far back as 15 and 17 years ago, metronidazole was inferior, and we believe that gap has only expanded further. So that explains metronidazole largely being removed. What about fidaxomicin? Why is this now the preferred treatment? Well, what makes fidaxomicin unique? Fidaxomicin is a narrow spectrum antimicrobial. By having a narrow spectrum, it targets C. difficile in a very specific way. And by targeting C. difficile in a very specific way, it minimizes what we call the collateral damage or the impact on the surrounding microbiota. By doing that, it preserves that microbiota and lessens the requirement of healing as the spore phase gets eradicated. Plainly stated, it should be associated with decreased rates of recurrence. That's the theory, and that's what's been shown in prospective randomized, blinded trials. This is the data presented by Tom Louie in the New England Journal of Medicine, now 11 years ago. Head-to-head trial, fidaxomicin 200 milligrams twice daily for 10 days, vancomycin 125 milligrams 4 times daily for 10 days, and then they were followed for 28 days or 25 days thereafter. The study was not powered to show a statistically significant difference in terms of initial treatment response. Initial treatment response for fidaxomicin, 88.2% versus 85.8% in the vancomycin arm. But when we focus on recurrence, and I focus you on the modified intention to treat analysis in the center of this slide, what we see is very impressive. Recurrence rates with vancomycin were 25.3% versus 15.4% with the fidaxomicin. Fidaxomicin is designed to be associated with decreased rates of recurrence by preserving the microbiota, and that's in effect what it does. So now we have an explanation for the recommendations for initial infection. What are the recommendations for first recurrence and second recurrence and beyond? For first recurrence, the preferred treatments are either fidaxomicin 200 milligrams twice daily for 10 days or fidaxomicin 200 milligrams twice daily for 5 days and then once every other day for days 7 through 25. An alternative treatment is the classic vancomycin taper pulse. And then finally, if somebody failed metronidazole initially, you can consider vancomycin in a 10-day treatment course. Importantly, within this recommendation, they added bezlotuximab, which is a fully humanized monoclonal antibody that's given as a one-time infusion. And we'll talk about that in a couple of slides. For second recurrence and beyond, or third episode, give them whatever they haven't gotten before. Either fidaxomicin regimen, a vancomycin taper, a 10-day treatment course of vancomycin followed by rifaximin, consideration for bezlotuximab if it hasn't been given already. And this is where fecal microbiota transplantation enters the discussion. So let's first talk about the extend data. The data for that unique usage of fidaxomicin, 200 milligrams twice daily for 5 days, and then once every other day, days 7 through 25. In effect, a 5-day treatment and then a pulse after that. And this is data from Gary and colleagues over in Europe. Looked at 364 individuals aged 60 and above who were hospitalized with C. difficile. As I mentioned, they either received 10 days of vancomycin or the alternative treatment course of fidaxomicin. And overall initial response were similar, 82.1% for vanco, 80% for fidaxomicin. But what I want to point your attention to is the center of this slide, that 90-day recurrence rate. 19.0% with vancomycin, 6.2% with the fidaxomicin. That is truly remarkable. In an over 60 population who's hospitalized, that's impressive. And that's why this was added to the guidelines as a viable treatment for first recurrence and second recurrence and beyond. What about just simply switching from vancomycin to fidaxomicin? This is a subgroup analysis from the original pivotal phase 3 trial comparing vanco and fidaxo that I discussed a couple slides ago. Those patients that received vancomycin a second time went on to recur 35.5%. Those that received fidaxomicin, 19.7%. So a near halving of the recurrence rates. So what we see is fidaxomicin is a great second-line treatment if somebody failed vancomycin initially. Now, many of us have been using vancomycin tapers for years. What's the data for a vancomycin taper? It's actually really poor. This is probably the best analysis that I found in recent times. It's an abstract from my friend and colleague Sahil Khanna at the Mayo Clinic in Rochester, Minnesota. Sahil looked at 128 patients through his clinical experience who received a vancomycin taper. Median duration was 50.5 days. The median age was 60.5. Overall recurrence rate, 41%. Not so good. Would you have thought that of a vancomycin taper that so many of us use? That's impressive. However, when they separated out those that received less than 6 weeks of a vancomycin taper versus those that received more than 6 weeks of a vancomycin taper, those that received more than 6 weeks had a recurrence rate of 37.0% versus 56.5% for less. So the pearl here is a longer taper is better, greater than 6 weeks. How about how we finish the taper? Stu Johnson looked at this retrospectively. 100 total patients, looked at those that received a standard finishing of the taper versus every other day, followed by every third day, a so-called pulse. That every other day followed by every third day had an 81% response rate versus 61%. So greater than 6 weeks and finishing with a pulse every other day followed by every third day can have a real positive impact. What about bezlotuximab? What is bezlotuximab? Bezlotuximab is a fully humanized monoclonal antibody designed to bind toxin B in a specific way. It is an add-on therapy in addition to a standard of care antimicrobial, and it is given as a one-time infusion. So what's the data for this? The data for this is actually really impressive. The Modify 1 and Modify 2 trials randomized patients with C. difficile infection. All of them received standard of care antimicrobial. Then they were randomized to either placebo, bezlotuximab, a combination of bezlotuximab and actuximab, or actuximab. Now, I mentioned bezlotuximab is a fully humanized monoclonal antibody to toxin B. Actuximab is a fully humanized monoclonal antibody to toxin A. But we don't talk about actuximab because it wasn't very effective and hasn't come to market. So focusing on 90-day recurrence rates between placebo and bezlotuximab, recurrence rates in the placebo arm were 28% versus 17% in the bezlotuximab. In terms of the Modify 2 trial, 26% versus 16%. The number needed to treat was 10 overall, but in an over 65 population, the number needed to treat was a very impressive 6. So now what I pose to the audience is, well, we have a new product. Where do we use it? What's our indication to use this product? And I'll point this Dale Girding subgroup analysis out that looks at risk factors for recurrence, 5 that were set a priori within the original controlled trial: age over 65, history of C. difficile within the prior 6 months, any form of immune compromise, severe infection, and the hypervirulent strains. If patients had 3 or more of those risk factors, recurrence rates in the placebo were 46.1% versus 21.2%. 2 risk factors, 41.1% placebo, 26.9% in the bezlotuximab arm. Even 1 risk factor for recurrence, 31.3% placebo, 17.1% in the bezlotuximab arm. So what we see is at least 1 risk factor for recurrence. An infusion of bezlotuximab after a standard of care antimicrobial can be very, very effective. Now, I've spoken to this point about the treatments of the vegetative phase, targeting the toxin with bezlotuximab, targeting the actual vegetative phase with antimicrobials. But in 2022 and beyond, no discussion of C. difficile infection is complete without discussing fecal microbiota transplantation and the so-called superhero effect. This slide is a slide that speaks to what I call the arc of efficacy of C. difficile infection and fecal transplant treating that and supplementing treating that over the last 10 years. And I point you first to the left-hand part of this slide, the Van Nood study, a New England Journal of Medicine manuscript, a prospective randomized controlled trial of patients with multiply recurrent C. difficile who received a nasoenteric transplant in one group, vancomycin and bowel lavage, or vancomycin alone. The study was stopped at interim analysis because of inferiority of the vancomycin arms. The nasoenteric transplant arm had an 81.3% efficacy, and this opened the floodgates for quite a few different studies over the subsequent years. And that, I believe, peaked in 2017 with the meta-analysis by Qureshi and colleagues that I'm showing you in the center of this slide. 6 prospective trials, 30 retrospective case series, overall efficacy of 92% for fecal microbiota transplantation. Many of us thought we would be putting ourselves out of business, which is a great thing, shutting down this infection and minimizing future recurrence. But like many things in medicine, when we look at better structured studies, we get a better estimate of outcomes. And the meta-analysis I show you on the right from 2017 looked at studies that had control groups. 13 studies, 610 total patients, overall efficacy of fecal microbiota transplantation, 76.1%. But when we unpack that further, we see that in open label trials, the efficacy was 82.7%. Randomized control trials, 67.7%. So the randomized control trials most likely mimic the real world impact. Still excellent, but not quite that 92% that we saw initially. Now, I'm quoting previously the investigator-initiated studies and the foundational studies, and the safety along these studies was pretty clear. for many, many years. Didn't seem to have any significant problems until 2019 in June, when we had a report from the FDA of 2 individuals who got multi-drug resistant organisms following a fecal transplant. Neither of them received a fecal transplant for C. difficile. One following a bone marrow transplant for prevention of graft versus host disease, and the other was as in a treatment of hepatic and prevention of hepatic encephalopathy. Importantly, these patients were transcribed extended spectrum beta-lactamase producing E. coli. Very scary, but certainly something that we now screen for. The other big time the FDA pointed to some safety concerns around FMT was March 12th, 2020. Where were you March 12th, 2020? I know I was thinking about COVID-19, but I certainly saw this come through the press circuit, and it is in fact important, and we need to talk about it. This was a report from the FDA of 6 individuals who were receiving stool through fecal transplant from a major stool bank. 2 of them got enteropathogenic E. coli. They did fine. 4 of them got Shiga toxin producing E. coli, and 2 unfortunately subsequently died. We do not believe that the patients died as a result of the Shiga toxin producing E. coli that they got. We believe it was from their medical comorbidities. However, we are learning the things that we need to be careful that we screen for. And what I'm really driving at is a shift from the past, where I show you the first FDA overseen fecal transplant that I performed at Yale New Haven Hospital back in 2013 under enforcement discretion, to the future, which are pharmaceutically produced products that have more predictable safety and efficacy and have gone through the appropriate clinical trials. And there are a number of these products, and it is such an exciting time for this. The first product I'm going to talk about is RBX 2660. RBX 2660 is a broad consortium, meaning it includes all types of microorganisms. It's rectally instilled. It has actually gone through quite a few clinical trials, including 3 phase 2 trials and 2 phase 3 trials. What I'm presenting to you is the pivotal phase 3 trial, a Bayesian analysis leveraging the phase 2 data with the phase 3 data, since the trials were performed in parallel with similar diagnostics and similar outcomes. And we see an overall efficacy of RBX 2660 of 70.4% versus 58.1%. The posterior probability of superiority was 0.986, a statistically significant difference. And my hope is that this will be presented to the FDA in the near future. And my hope is that we get a potential approval for this product. Very, very exciting, a rectally instilled product given directly to the site of infection. Another product is SER-109. This is a capsule product that is a narrow consortium. It only includes Firmicutes spores, a deficiency in patients that have C. difficile. Within this trial, patients were randomized, all of them received standard of care antimicrobial, to either receive SER-109, 4 capsules daily for 3 days, versus placebo. Overall efficacy of this product, 88% versus 60% in the placebo arm. Now, the diagnostics between the 2 studies differed, so this is probably explaining some of the differences that we see, but this too is an incredibly exciting product. And my hope is this also goes before the FDA as a potential product that will gain approval. What about CP101? CP101 just finished a phase 2 trial, so it's a little bit further behind, but it is a capsule formulation that is a broad consortium similar to RBX 2660, but in a capsule form. And within their phase 2 data, they had exciting results as well. At 8-week follow-up, efficacy was 74.5% versus 61.5%. And finally, and most recently, VE303 reported in press release format their data, which is a synthetic 8-microbe consortium. Their high-dose arm within their clinical trial at 8-week follow-up had an 86.2% efficacy versus 54.5% efficacy. Now, across all these trials, patients received standard of care and then were randomized to either placebo or the intervention. But you can see why the excitement is so palpable with these products, because we're at the precipice of greatness for an FDA-approved product. So pulling back on everything, what is my treatment algorithm? For initial infection, I think about risk factors for recurrence. If patients have less than 2 risk factors for recurrence, I give them vancomycin. If they have more than 2 risk factors for recurrence, I give them fidaxomicin. Also, if they have more than 2 risk factors for recurrence, I consider an infusion of bezlotuximab. Shutting down the cycle of recurrence before it actually happens is the best methodology we have. If somebody fails vancomycin, I give fidaxomicin either as 10 days or the alternative extend treatment. If they failed fidaxomicin initially, I give a prolonged vancomycin taper with a pulse at the end. Again, if they haven't received bezlotuximab and have more than 2 risk factors for recurrence, I will give them bezlotuximab. And finally, with that second recurrence, third episode, this is where I give a standard of care antimicrobial followed by fecal microbiota transplantation.